case that we've seen. It was a case of a patient who presented quite unusually and precipitously as with takotsubo, and there's been a number of reports previously of Phaeochromocytoma presenting as takotsubo cardiomyopathy. So in this case, we had a 48-year-old lady who was a Caucasian with no previous medical history. She presented to ED, the emergency department, with headache and hypertension, and then was discharged after her blood pressure improved without any treatment, and was told to see her general practitioner to try and get some treatment at that time. But shortly afterwards, she was sent back to hospital for 4 days later with blood pressure of 220 systolic. They decided they would scan her head because of headaches, and at that time she had acute shortness of breath and acute pulmonary edema, and the ECG changes were suggestive that she had an acute coronary syndrome. So and with the significant breathlessness that she had, she ended up being intubated and sent for further examination with an angiogram. Her troponin tests were positive, and her ECG basically showed some ST elevation in AVL and some dynamic lateral T-wave inversion. And the chest X-ray, which is demonstrated in the poster, shows that she's got bilateral pulmonary infiltrates, and had an angiogram done which showed that she had normal coronary arteries, but the ventriculogram showed that she had apical ballooning with severe sort of LV impairment. She had quite a stormy course in the cardiovascular ICU, where she had a PEA arrest and had 10 minutes of CPR. They managed to get return of spontaneous circulation for her, and she was commenced on ECMO for 4 days, and had really difficult to control hypertension because of with any movement that she made, or coughing or movement in the bed, she would have these surges of hypertension and tachycardia. Needless to say, with the diagnosis of takotsubo cardiomyopathy was made on the toe transesophageal echo, which showed an LVEF of 10 to 15%. And so the diagnosis was takotsubo, but with the hypertension, she had plasma metanephrines done, and they were exceptionally high. So in our measurement, the usual range is less than 500 for plasma metanephrines. They were greater than 85,000. So she was supported on ECMO for 4 days, and then she had recovery of her left ventricular function, and then she was stabilized on alpha blockade and beta blockade, and then had uncomplicated surgical resection on day 17 after presentation, was discharged about 6 days later, well, and without any antihypertensives whatsoever. I guess the discussion points that we have is that for the presentation is that this takotsubo can be a presentation of phaeochromocytoma, and you need a high index of suspicion. Sometimes the takotsubo presentation is the diagnosis, and it can take a while for people to actually figure out that that they have phaeochromocytoma in the background. The other discussion point that I put up is that the takotsubo patients who have phaeochromocytoma in the background are different, have a different profile to your standard takotsubo group. So the recent studies have shown of this group, which probably ranges from sort of 80 to 100 patients in the literature, has an average age of 46 years old rather than 66 for the standard patient. Also, they are more likely to produce, more likely to occur without the classical stresses that you will often see with such as, broken heart syndrome, or people who have recently had psychological stresses, or the like, which are classical for takotsubo. They're also a lot more likely to have cardiogenic shock, and in fact, obviously, it seems obvious that inotropes should be best avoided, and ECMO is a a good mechanism that's been utilized to support their cardiac function while they recover from their takotsubo. And some recent studies have shown that the average is about 5 days of ECMO, and that 80% had recovery of cardiac function. The other thing about a patient is that her CT scan had shown that she had hemorrhage or necrosis, and within the site of the large sort of Phaeochromocytoma that she had, and that may have influenced her precipitous presentation. We think that she probably had a small hemorrhage within the Pheo, which had made her so unstable from a period of time where she was reasonably stable. I think that's most of my discussion points, really. I'm happy to answer any questions if there are some. I know it's late in the day.
Dr. Erin, thank you very much for this poster presentation and interesting case to present here. I'm not sure if there is any question from the audience.